contributes to plaque progression, plaque destabilization, and thrombotic complications.
So any of our labs check oxidized LDL? So it is considered to be a much better marker than conventional LDL that we see, right?
Yes. Oxidized LDL, because that is the starting foam cell is the starting form of the atherosclerosis. If the lab is able to identify oxidized LDL, that is the first step we are targeting. So basically, the residual inflammatory risk refers to persistent vascular inflammation in patients with well-controlled LDLC despite optimal guideline-directed medical therapy, contributing to recurrent atherosclerotic events. So the only indicator as of now is hsCRP. It's a acute phase reactant synthesized by hepatocytes, mostly stimulated by IL-6. So based on this, the hsCRP risk stratification is at less than 1 mg per day, there is a low risk. 1 to 3 mg per liter, it is moderate risk. More than 3 mg per liter is a high risk. But if you get a value that is more than 10 mg per liter, you are supposed to repeat it because that is mostly due to an infection or an inflammation. So even on repeat after like 1 or 3 weeks, still it is like you should consider second option rather than inflammatory of the cardiac. See, there was this one clinical evidence linking hsCRP to CV outcomes. There was this study in 2019. hsCRP level and the risk of death or recurrent cardiovascular events in patients with MI. The objective was to determine how hsCRP levels after MI relate to risk of recurrent major adverse cardiovascular events and all-cause mortality in real-world healthcare population. The included patients were all the MI survivors undergoing hsCRP testing more than 30 days after the MI during routine healthcare. It had excluded patients who had hsCRP tests measured during emergency department visits, followed by antibiotics or indicative of acute illness, or if the patient was having ongoing or recent cancer, chronic infections, or immunosuppressions. Approx study population was of 17,464 patients with median hsCRP level of adjusted analysis. Patients with hsCRP more than or equal to 2 mg per liter had a risk of 1.42. The hazard ratio was 1.42. High risk of death, and that was attributable to both cardiovascular and non-cardiovascular causes. And patients with hsCRP more than 2 had a hazard ratio 1.28 for mix. Same thing shown in this. So in this study,
go back to that previous slide.
yes.
So there were more than 17,000 patients, right?
Yes.
So median CRP was 2.2. જેમાં આ જે 2 કરતા વધારે છે એનો હેઝાર્ડ રેશિયો 1.4 1.2 સમથિંગ રાઈટ તો જેનો 2 કરતા ઓછો હતો એનો હેઝાર્ડ રેશિયો કેટલો છે જોયું છે તમે આગળ આવશે
નહીં સર એ લેસ ધેન 2 વાળું નથી
how will you compare right median 2.2 છે તો there must be some thousands of patients કે જેનું 1 હતું 0.5 હતું તો એમાં ઇવેન્ટ્સ શું છે that we should know ના
yes that was આજે ગ્રાફમાં સ્ટ્રેટિફાઈ કર્યા છે એને so that was very
અહીંથી તો મારું બચાતું નથી મેં તમને
જે all cause mortality છે અને hsCRP જે આ flat line છે that is less than 1 mg per liter so એમનું survival probability was like 1 for those with MV survival probability did not reduce that much, and this is the middle line which is of 3 mg, that survival probability had reduced to a greater extent. They had substratified these for both all cause as well as for MACE. So the first straight line is for less than 1 mg per liter. I don't have the exact values.
So you should also tell values, right?
Yes, I forgot to write the values. But based on this graph, the survival probability reduced to a certain great extent.
So median follow-up 3.2 years નું હતું. તો ઇમ્પ્રેસ ના થઈ શકે એનાથી.
This was just to show the plateau effect that after mostly 5 mg per liter CRP, the risk or the hazard ratio plateaus enough for both all-cause mortality as well as for MACE. So there is not much more increase after the increase in hsCRP.
then how important this particular tool HSCRP should be?
Like for follow-up patients of MI, we don't expect like for a patient to always have an infection. If that 3 to 5 is the only sensitivity part of the HSCRP.
So that's the whole part. That the small range is correlating. That means the lower range and higher range doesn't have any sensitivity or specificity.
Yes.
Then this tool should be useless because it does not tell you the risk stratification.
Yes, but this is the only.
Right? So in a way they are showing us that it's very important nothing.
But
right?
अगर inflammatory risk matter there are indicators and all the studies which are happening they are not correlating with HSCRP.
Exactly.
That is the main point. They have
Exactly.
based the entire studies on HSCRP. The fact that the HSCRP rises, but all the studies that are done, they are not comparing the
अभी એ જ કહેવા માંગે છે કે જ્યારે કોઈ પણ ટૂલનું એક પર્ટિક્યુલર સેક્શન જ કોરિલેટ થતી હોય બાકીનું ના થતું હોય that means the tool is not very important.
It's only the one that range that is significant and if it falls with the clinical scenario.
એવો જ એક HSRP રિલેટેડ એક આર્ટિકલ કે હમણાં જ સ્ટડી પબ્લિશ ફોરેન સેલમાં કેવું કંઈક નામ છે આર્ટિકલ in which what they had found that those who are having a herpes zoster, that is a chronic inflammation, they are likely to have such type of infarction or CV stroke even 66% in first year after herpes zoster.
66%.
66% are having a CV stroke or myocardial infarction in first year after this herpes zoster.
Okay.
I don't know, I have that article also here.
Basically now all HCCR are basically trying to tell you that there is persistent inflammation, you are at a high risk of having a cardiovascular, either stroke or MI. So inflammation should be the target as like the main risk factor that you should target for reducing the recurrent events. That is
And
what
based
the
on
gist
that
of all the articles is there.
And based on that particular article, now that serious people are coming out with big way that every cardiovascular patient should be given this particular vaccine. And they are holding a big event, probably a nationwide event on 22nd March.
There has to be more of a marketing gimmick.
कंपनी वाला एक तो लगे
खबर नहीं
Since last 2-3 years, there is one article which says that inflammation should be the target of new target, apart from statins.
Suppose if I do a PET CT of a chronically inflamed coronary artery disease, what you will get?
There would be, if it is a chronic, there will be calcified plaques. I'll have a high calcium.
I am saying chronically inflamed.
Inflamed.
Yeah, there is inflammation going on. આપણા ટાઈપના હાઈ રિસ્ક પેશન્ટ કે જેમાં આપણે we are caring કે આને ઇવેન્ટ ના થાય.
There will be some.
You would expect some increased FDG.
Yes,
You would expect. Then why there are no studies, there are no reports? Because they know that probably it will not correlate.
They don't. That is the thing. The inflammation is. There is no exact correlation of the
Exactly.
inflammation and that. They have only correlated the outcomes.
Outcomes.
See, the outcomes will also be good because the patient will be on guideline medicated therapy. Complete. You will give them AC inhibitors, you will give them beta blockers, they will be on dual antiplatelets, they will be on statins, and we will target statins with LDL less than 100. So that is there. But that is what the treatment minus placebo effect is not yet that significant.
Exactly.
But this is something that is being targeted.
ચાલુ રાખો ને બેન તમ તમારે.
Huh? So the clinical perspective was that HSCRP is a marker of systemic inflammation is clinically elevated in most healthy and managed patients with MI, and HSCRP is associated with subsequent risk of major adverse cardiovascular events in death, with associations being linear for HSCRP ranging between 1 and 5 mg per liter and plateauing thereafter to a sustained increased risk. So based on this, anti-inflammatory drugs were used in trials. The first was Cantos study enrolled only 530 patients and was not placebo controlled. Based on this low-dose study, we talking about colchicine. It's a natural alkaloid extracted from colchicine coronary. The mechanism is it binds to beta tubulin, which inhibits microtubule assembly and disrupts the cytoskeleton dependent process. So basically inhibits the migration of the inflammatory cells, and it inhibits NLRP3 inflammasome activation, reduces caspase activation, reduces interleukin beta 1 and interleukin 18 production. It also reduces IL-6 and CRP levels, decreases neutrophil chemotaxis, adhesion and superoxide release. So basically for cardiovascular, it attenuates vascular inflammation, stabilizes atherosclerotic plaque and reduces residual inflammatory risk post-MI. The absorption oral bioavailability is approximately 45%. Peak plasma concentration is 1 to 2 hours. Mostly protein form, so large distribution. Metabolism is hepatic. Elimination is 26 to 31 hours, which is prolonged with chronic dosing, and it is excreted via biliary renal pathway. Dose adjustment is required in renal impairment patients. Side effects most common is gastrointestinal intolerance, diarrhea, nausea, and abdominal pain. Serious dose dependent is myopathy, which is increased risk with statins, bone marrow suppression, rare, and hepatotoxicity. So, yes, based on all these three trials, Colchicine trial came into picture. The objective of the Colchicine trial was to evaluate the effects of colchicine on cardiovascular outcomes as well as long-term safety profile in patients who had recently had a MI. So it was a randomized double-blind placebo control. Patients who suffered a myocardial infarction within the last 30 days were randomized to colchicine 0.5 mg daily versus placebo. So the inclusion criteria was patients having MI within 30 days and had completed all intended coronary revascularization. The exclusion criteria was type 2 myocardial infarction, severe left ventricular systolic dysfunction or heart failure, stroke within last 3 months, CABG within last 3 years, cancer within last 3 years, and any history of inflammatory bowel disease or chronic diarrhea, neuromuscular or significant hepatic or renal disease, or drug or alcohol abuse, or on steroids or is having sensitivity to colchicine.
What is type 1, 2, 3 myocardial infarction?
So type 1 is due to rupture of any plaque or acute MI. Type 2 is due to any mismatch in the demand oxygen and the demand mismatch. Type 3 is when a patient is having sudden cardiac death and you suspect it is due to MI because of the symptoms previously known. Type 4 is when there is MI after PCI, and type 5 is MI after CVD.
पास करे तो पास
हाँ सर
मैडम ने पास करो
એ તો સાહેબ તમે કરી શકો આપણે તો ઓકાત નથી આપણે હજી શીખીએ છીએ
So approximately 4,500 patients were randomized. Clinical evaluations occurred at 1 month and 3 months after randomization and every 3 months thereafter. So, coming to the results, the primary composite endpoint was of cardiovascular events, resuscitated cardiac arrest, MI, and urgent hospitalization of angina for angina leading to emergency revascularization. So the major benefit of this trial was seen in the patients for stroke, reduction in the stroke event, and reduction in the urgent hospitalization for angina leading to revascularization. So that in colchicine it was in 5 patients compared to 19 in placebo for stroke, and for the hospitalization was 25 compared to 50. The hazard ratio was also 0.77 for the composite primary end event. So it was 5.5 versus 7.1, and it was a statistically significant value. This was for the adverse event. There was no increased adverse event with colchicine. All the events were almost similar. This study had, for inflammation of biomarkers, this study had included HSCRP protein was measured in a subgroup of only 207 patients at the time of randomization and 6 months later. The median concentration of the HSCRP trial was 4.2 mg per liter. The baseline characteristics was same for all the subgroup of patients. The adjusted geometric mean percentage changes in HSCRP level at 6 months after MI was -70% in colchicine group and 66% in placebo group. So the placebo adjusted geometric this was a very small subgroup, so it could not be statistically significant. So this was the only study which had this subgroup of patients. So the conclusion was patients who have suffered a recent MI, low-dose colchicine was effective at preventing major cardiovascular events compared to placebo. But this primarily was due to reduction in the incidence rate of stroke and urgent hospitalization for unstable angina leading to revascularization. The study drug was well tolerated and associated with similar incidence of infection and diarrhea compared to placebo. So no side effects, increased side effects. Colchicine was also cost effective, and the benefit was given to the anti-inflammatory properties of the drug. The limitations of the study was the duration of follow-up was relatively short, only 23 months. Results applied to patients who had recent MI. Primary outcome had a low fragility index, so any change in the value, 1 or 2, the result can be easily challenged. The results did not involve the HSCRP level reduction as such, the end results. This led to the two trials, NODOCO-2 trial, colchicine in patients with chronic coronary disease. So the objective was to test if colchicine 0.5 mg daily can lower the risk of major cardiovascular events, that is death, MI, stroke or revascularization in patients with stable coronary artery disease. It was again randomized double-blind placebo control. The inclusion criteria was age 35 to 82 years. Evidence of coronary disease on invasive coronary angiography or computed tomography. Angiography or a coronary artery calcium score more than 400 units, and the patient was having clinical stable condition for more than 6 months. The exclusion criteria was moderate to severe renal impairment, severe heart failure, severe valvular heart disease, and known side effects of colchicine. The patients were entered in an open label run-in phase for 1 month. So after taking for 1 month colchicine, if the patient is not having any trouble or any side effects and he still wants to continue with the participation, then they were randomly assigned in a 1:1 ratio. So clinical evaluations were scheduled before the running phase at the time of randomization and 6-month interval until completion of trial. Approximately a total of 5,520 patients underwent randomization. These were the baseline characteristics of the patients that were involved. Most of the female ratio was less, only 16% of females were involved. Almost 51% had hypertension, and most of those patients involved had stable condition for more than 24 months. So approximately 56% of the patients had stable condition for more than 24 months and had last MI 24 months before. Almost 83% had undergone revascularization in any form, either PCI or CBG, and 93% were on statins. So nearly all the patients were on statins. The result, the primary endpoint was cardiovascular death, MI, stroke or ischemia-driven coronary revascularization. It was 6.8% in colchicine and 9.6% in placebo, with a hazard ratio of 0.69, which was significant, statistically significant. The secondary endpoint was the subgroup of that. In that, significant was MI or ischemia-driven coronary revascularization. That was 5.6% with colchicine and 8.1% with placebo. Again, it was statistically significant. So this was the main results in the trial. Again, the graph that shows that the hazard ratio for primary endpoint was lower, and this is for this key secondary endpoint, that is MI or MI leading to revascularization. So that hazard ratio was 0.7. So the conclusion is patients with chronic coronary disease, most of them are already receiving proven secondary prevention therapies. 0.5 mg of colchicine once daily resulted in 31% lower risk of cardiovascular death, spontaneous myocardial infection, infarction, ischemic stroke or ischemia-driven coronary revascularization. No evidence of clinically important interaction between low dose of colchicine and high were monitored. There was nothing, no study was comparing any risk factor that is being controlled, so if there is an effect of that also. Because outcome can be reduced due to reduction in like control of hypertension, control of sugar, control of smoking.
કોઈ પણ ટ્રાયલ ની જે બેઝિક સીટ હોય એમાં વાઇટલ્સ લખેલા.
हाँ, ये तो मैं
It was not followed.
followed.
ના આમાં લખ્યું was not measured at baseline.
हाँ, ये नहीं actually not
બેઝલાઇન પણ એથી મેઝર નથી કર્યું યાર હવે આ તો કઈ રીતે ગળ્યું?
Lipid levels were not. CRP levels or other laboratory indicators of inflammation was not measured at baseline. So the effects of treatment cannot be explored according to inflammatory state at baseline.
It is a sponsored trial or a neutral trial?
એવું જ હોય તો
So based on these two trials only, FDA had approved Colchicine for decreasing CV events in 2023. And based on these two trials only, there were guideline recommendations for ESC 2024 guidelines for chronic CAD. Low dose Colchicine can be considered to reduce recurrent MI, stroke, and need for revascularization. It was 2A indication. For ACC guidelines, it is still 2B indication. The poor risk, evidence risk for chronic CAD. For acute ACS, ESC guidelines have no role. ACC is like maybe responsible post ACF for reducing MACE, but still there are neutral trials, so the evidence is lacking. There are still trials that are going on for acute MI. Still the results are awaited.
So what are other things you will consider while you are putting patients on colchicine?
So if the patient if the renal function, hepatic function, as well as we have to see if the CBC is also not that much suppressed. So if all of that is permissible, then only I can keep the patient on colchicine. So rather than benefit, then I have increased risk of infection and immunosuppression.
You can also have myopathy
And
when your patient is mostly on high dose statin, right?
Yes, high dose.
And another thing, it is very highly metabolized by cytochrome enzymes. So inducer and inhibitors, ખાસ કરીને inhibitor will increase the level of colchicine. So side effects but hormones, right? So that's a very important thing you should always keep it.
Yes.
હવે એઝિથ્રોક્લેરિન તો આમ ચાલતી હોય ફટ.
That is one thing.
Is there any interaction between aspirin and colchicine?
So there is no study yet.
સમય લેતા એવું આવશે કે એસ્પિરિન બંધ કરી દો સાઈડ પછી કોલ્ચિસિન ચાલુ કરો.
It's not possible at all. But આમાં ક્વેશ્ચન બહુ મસ્ત રાઈઝ થાય કે તમે આ ક્રોનિક ઇન્ફ્લામેશનને ટાર્ગેટ કર્યું, કોલ્ચિસિન વડે કર્યું. હવે હું ક્રોનિકલી પેરાસિટામોલ કે પાયરોક્સિકેન કે તમારું આ બધું આપું તો એ કેમ ઇન્ક્રીઝ કરે છે? You will not give NSAIDs if you want to treat any coronary patient because it will increase the event. They are though anti-inflammatory. Why? So if you go traditionally, the diclofenac na બધું જો તમે chest pain વાળા patient ને આપી દો તો they have said that they might increase the event, right? Because they પેલું COX inhibitors છે અને I think prostacyclin નો પેલું લેવલ ઘટાડે છે એટલે vasoconstriction થાય ને blah 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 બધું છે. So in spite those are anti-inflammatory, they are contraindicated, and this is again an anti-inflammatory which is indicated probably, right?
high HSCRP. Indomethacin in a high HSCRP any study you ever?
Sir, I'm not. There were only 3 drugs which were seen. After methotrexate, none of those drugs were released. Only canakinumab and this. With HSCRP, there are new drugs which are genome trial. Apart from statins, who are targeting direct HSCRP levels or interleukin, pentavalent.
Gout. Most important is gout.
Gout.
It is basically brain gout.
ચાલો હવે સાહેબ જોશથી પૂછે એ પેલા નીકળી જજો.
Gout ની અંદર acute inflammation તે આપણી 1 hourly 1 ટેબ્લેટ.